A 69-year-old man named Reginald came to me 22 months ago. He had been a secondary school mathematics teacher for 35 years. Logical, systematic, the kind of man who believed that every problem had a solution and that finding the solution was simply a matter of applying the right methodology with sufficient rigor. He had been applying rigor to his blood pressure for 4 years. He had taken every medication his GP had prescribed. Without missing a dose, he had reduced his dietary sodium. He had stopped adding salt to anything. He had walked 40 minutes every morning. He had reduced his alcohol to 2 glasses of wine per week. He had lost 9 kilograms. He had done everything that had been asked of him with the methodical precision of a man who marks his own work carefully and expects the grade to reflect the effort. His blood pressure was 158/94. 4 years of full compliance, 4 medications at moderate to high doses, a calcium channel blocker, an ACE inhibitor, a thiazide diuretic, and a beta blocker. 4 years of lifestyle changes that would have been considered exceptional by any clinical standard, and a blood pressure that had not moved below 150 systolic in 14 months, despite everything. His cardiologist had described it as resistant hypertension and was considering adding a 5th agent. His GP had suggested the stress of retirement adjustment might be a contributing factor. His wife had begun monitoring his readings every evening and recording them in a notebook that she brought to every appointment. The notebook showed the same thing every evening, numbers that should not be where they were in a man who had done everything right. Reginald came to me not because anyone had referred him. He came because he had run out of explanations. He had been a mathematics teacher. He understood that when the answer was consistently wrong, despite the correct method, the problem was not the method. The problem was an assumption that had not been examined. He wanted someone to examine the assumptions. When I reviewed his case, not just his medications and his lifestyle, but his complete clinical picture, his sleep, his weight distribution, his medication timing, his history of workplace exposures, his complete kidney function panel, and the one investigation that had never been performed in 4 years of resistant hypertension management, the assumption that had not been examined became immediately apparent. And it was not the assumption anyone had thought to question, because it was invisible, because it happened while he slept, because the blood pressure cuff that recorded his numbers at the evening monitoring session and at every GP appointment measured what his cardiovascular system was doing during the hours it was visible, and the damage was being done during the hours nobody was measuring. I'm Dr. Kevin Adewale. I'm a cardiothoracic surgeon. I spent over 30 years operating on hearts, repairing arteries, and reviewing the cases of patients whose blood pressure refused to respond to everything medicine had offered, and finding, in the majority of those cases, a cause that had never been formally investigated, because it did not present itself during a standard consultation. What I'm about to share with you, most doctors won't bring up at your annual checkup, but after 60, it matters more than you think. Today, I'm going to tell you the hidden reason that blood pressure refuses to come down in millions of adults who are doing everything they have been told. I'm going to explain what is happening inside the cardiovascular system during the hours when nobody is measuring, what the specific cause of treatment-resistant hypertension is in the majority of cases where it has not been identified, and exactly what investigation and what conversation needs to happen before any additional medication is considered. Stay with me, because the mechanism I am going to describe is operating in the bodies of millions of adults right now during every hour of their sleep. And most of them have been told their blood pressure is the problem, when their blood pressure is the consequence. Before I tell you what the hidden cause is, I need you to understand something about how blood pressure is supposed to behave during sleep. That most people, and some clinicians outside specialist cardiology and sleep medicine, have never been clearly told. Because this understanding is the foundation on which everything else I am about to describe makes sense. Think of it this way. Blood pressure in a healthy cardiovascular system does not stay at the same level around the clock. It follows a predictable 24-hour pattern, a circadian rhythm of its own that is governed by the autonomic nervous system, by the sleep-wake cycle, and by the hormonal changes that accompany the transition from waking to sleeping. During the day, blood pressure is elevated, appropriately so because the cardiovascular system is supporting physical activity, cognitive demand, emotional response, and the metabolic requirements of an active body. In the early evening, it begins to fall. During sleep, particularly during the deep non-REM stages, it falls further. In a healthy adult, nocturnal blood pressure is approximately 10 to 20% lower than daytime blood pressure. This predictable overnight fall is called dipping, and it is not incidental. It is one of the most important cardiovascular maintenance events in the 24-hour cycle. During that dipping period, when blood pressure is at its daily minimum, the arterial walls decompress. The endothelium, the inner lining of every artery in the body, conducts repair of the microdamage accumulated during the day's pressure load. The heart rate is at its lowest. The cardiac output is at its lowest. The entire cardiovascular system is in its recovery and maintenance window. Every hour of normal nocturnal dipping is an hour during which arterial inflammation is reduced, endothelial repair is conducted, and the mechanical stress on the arterial wall is at its minimum. A person who dips normally every night is giving their cardiovascular system approximately 8 hours of reduced pressure recovery every 24 hours. Their arteries are recovering while they sleep. A person who does not dip, whose blood pressure remains elevated throughout the night at levels close to their daytime readings, is receiving no recovery window. Their arteries are under full pressure load around the clock. The endothelium cannot repair what is continuously being damaged. The arterial wall accumulates stress without respite, and the antihypertensive medications that have been prescribed to control the daytime reading are doing what they were prescribed to do during the hours when their concentration is highest and the blood pressure is being measured. But the nocturnal pressure that nobody has measured is running unchecked. The damage is accumulating in the dark. Non-dipping, the failure of blood pressure to fall adequately during sleep, is not a rare phenomenon. Research published in the Journal of the American College of Cardiology found that non-dipping or reverse dipping, where nocturnal blood pressure actually rises above daytime levels, was present in approximately 25 to 30% of adults with hypertension. In adults with resistant hypertension, blood pressure that does not respond to 3 or more medications, the proportion with abnormal nocturnal blood pressure patterns is substantially higher. And the clinical consequence of non-dipping is not merely a different blood pressure number at 3 in the morning. It is a threefold higher risk of cardiovascular events and organ damage compared to adults with the same daytime blood pressure who dip normally. The same daytime reading, a different nocturnal profile, a categorically different cardiovascular risk, and almost nobody with resistant hypertension has had their nocturnal blood pressure measured. The investigation is called ambulatory blood pressure monitoring, a small, portable device worn on the upper arm for 24 to 48 hours that measures blood pressure automatically every 15 to 30 minutes throughout the day and night. It captures the full 24-hour blood pressure profile, the daytime readings, the nocturnal readings, the dipping pattern, the morning surge. It tells the clinician something that no clinic reading, no home morning measurement, and no evening notebook can tell them. It tells them what the blood pressure is doing while the patient is asleep. And that information in a patient with resistant hypertension is the information most likely to identify the hidden cause of the treatment resistance. Reginald had never had an ambulatory blood pressure monitor. In 4 years of treatment-resistant hypertension managed by a GP and a cardiologist, the investigation that would have shown what was happening during the 8 hours of the 24 that nobody was measuring had never been requested. His wife's evening notebook was capturing one data point from one moment of the 24 hours. The ambulatory monitor would capture 90. When Reginald wore his ambulatory monitor for 48 hours, the picture was unambiguous. His daytime average blood pressure and the readings taken during his waking hours was 152/88, elevated, inadequately controlled despite 4 medications, but his nocturnal average blood pressure was 164/97. His blood pressure was not just failing to dip, it was rising during sleep. He was a reverse dipper. His arteries were under greater pressure at 3 in the morning than they were at 3 in the afternoon. His cardiovascular recovery window was not reduced. It was absent. His arteries were being subjected to the maximum pressure load during the hours when the entire biological design of the human cardiovascular system was supposed to be giving them relief. And the reason his blood pressure was rising during sleep, the hidden cause that had been present and undetected for 4 years, was obstructive sleep apnea. Here's what is actually happening inside the body during an obstructive sleep apnea episode. The person falls asleep. The muscles of the upper airway, the tongue, the soft palate, the pharyngeal muscles relax in the normal transition to sleep. In a person with obstructive sleep apnea, that relaxation allows the upper airway to collapse, partially or completely. Airflow is reduced or stopped. Oxygen levels in the blood fall. Carbon dioxide rises. The brain, detecting the hypoxia and hypercapnia, fires an emergency response. The sympathetic nervous system activates. Adrenaline is released. The person arouses from sleep, usually not fully, not to conscious waking, but to a lighter sleep stage in which the upper airway reopens and breathing resumes. Blood pressure spikes during that arousal response, heart rate spikes. And then the cycle begins again. The person returns to deeper sleep. The airway collapses again. The oxygen falls again. The adrenaline fires again. The blood pressure spikes again. In a person with moderate to severe obstructive sleep apnea, this cycle happens between 30 and 60 times per hour. 30 to 60 blood pressure spikes per hour for 7 or 8 hours of sleep. Every night, the sympathetic nervous system is repeatedly activated during the hours when it should be at its quietest. Adrenaline surges through a cardiovascular system that was supposed to be in its recovery window. Blood pressure does not dip. It spikes repeatedly through the night. And the antihypertensive medications taken at bedtime or in the morning, as most people take them, are metabolized over their therapeutic window and cannot cover the nocturnal spike that sleep apnea is producing with an intensity and frequency that no oral medication was designed to match. Tuppen, the chronic sympathetic activation of untreated obstructive sleep apnea does something beyond the nocturnal blood pressure spikes. It permanently upregulates the sympathetic nervous system's baseline tone. The body that is repeatedly shocked awake by hypoxia 30 times per hour learns, over months and years, to run at a higher sympathetic baseline during the waking hours as well. The stress hormones circulate at elevated levels, not just during the apnea episodes but throughout the day. The renin-angiotensin-aldosterone system, the hormonal cascade that is the primary long-term regulator of blood pressure, is activated by chronic sympathetic stimulation and produces sustained sodium retention and vasoconstriction that persists from morning to night. The daytime blood pressure that the cardiologist is trying to control with 4 medications is being driven not just by arterial stiffness, dietary sodium, or vascular inflammation. It is being driven by a sympathetic nervous system that has been chronically overactivated by nightly hypoxia and has reset its baseline accordingly. This is why 4 medications fail. They are managing the consequence. The cause is occurring 8 hours a night in the upper airway, and until the upper airway is treated, the consequence cannot be fully controlled by any number of medications. Targeting the blood pressure itself. Research from the New England Journal of Medicine confirmed that obstructive sleep apnea was present in approximately 83% of adults with resistant hypertension, those whose blood pressure remained uncontrolled on 3 or more medications. 83%. Not a minority. Not an unusual finding. The most common identifiable cause of treatment-resistant hypertension in adults, and in the same research, treatment of obstructive sleep apnea with CPAP therapy, The continuous positive airway pressure device that maintains the upper airway open during sleep produced significant and sustained reductions in both daytime and nocturnal blood pressure, in some cases eliminating the need for one or two of the antihypertensive medications that had failed to achieve control while the apnea was untreated. Let me ask you something directly. Do you snore? Have you been told by a partner or family member that you stop breathing during sleep? Do you wake in the morning feeling unrefreshed despite what should have been adequate hours of sleep? Do you experience excessive daytime sleepiness, falling asleep during quiet activities, struggling to stay alert in meetings or while watching television? Do you wake with headaches? Do you urinate more than once during the night? These are the clinical hallmarks of obstructive sleep apnea. They are present in Reginald's history, mentioned briefly, and never formally investigated, because they did not seem connected to blood pressure in the way that a high-cult diet or a sedentary lifestyle did. They seemed like separate minor inconveniences of aging. They were not separate. They were the mechanism. Tell me in the comments, how many of those features do you recognize in yourself or in someone you live with? Because those answers tell me how many people are in Reginald's position, treating the consequence with medications while the cause continues every night at full volume. But obstructive sleep apnea is not the only hidden cause of resistant hypertension. I want to be complete with you because resistant hypertension has several specific identifiable causes that are consistently overlooked in standard management, and any one of them or any combination of them may be the hidden reason that blood pressure refuses to come down in your specific situation. The second hidden cause is primary aldosteronism, a condition in which one or both adrenal glands, the small glands sitting on top of the kidneys, produce excess aldosterone independently of the normal renin-angiotensin signaling that is supposed to govern aldosterone secretion. Aldosterone is the hormone responsible for instructing the kidneys to retain sodium and excrete potassium. When it is produced in excess, the kidneys retain more sodium than the body requires. Fluid volume expands, blood pressure rises, and because the aldosterone production is coming from the adrenal gland itself rather than from the renin-angiotensin pathway, the medications that target that pathway, ACE inhibitors, ARBs, are partially ineffective. The driving signal is bypassing the mechanism those drugs block. Primary aldosteronism is not rare. Research published in the Journal of the American College of Cardiology found that it was present in approximately 20% of adults with resistant hypertension, making it the second most common identifiable. Because after obstructive sleep apnea, it is diagnosed with a simple blood test, an aldosterone to renin ratio, that takes one blood draw and costs essentially nothing. In the majority of cases, it has never been requested. The GP managing resistant hypertension adds a fifth antihypertensive medication, while the adrenal gland continues producing the hormone that is overriding everything. The specific sign that should prompt the aldosterone to renin ratio test beyond simply having resistant hypertension is a serum potassium that is low or at the low end of normal despite taking a potassium-sparing medication or an ACE inhibitor. Aldosterone drives potassium excretion. A low potassium in the context of resistant hypertension is the adrenal gland communicating through the electrolyte panel. It is a sign that warrants the test, and it is a sign that is frequently noted, attributed to medication, and not pursued. The third hidden cause is the medication and supplement list itself. Specifically, the medications and supplements that raise blood pressure as a side effect and that are being taken alongside the antihypertensive medications without anyone having fully identified the interaction. Non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac are the most significant offenders. NSAIDs reduce renal prostaglandin synthesis, decreasing renal blood flow and causing sodium and water retention that directly elevates blood pressure. They blunt the efficacy of virtually every class of antihypertensive medication through this mechanism. An adult with resistant hypertension who takes ibuprofen 3 times a week for arthritis pain is partially counteracting their antihypertensive medications with every dose. The cardiologist adding a fourth drug does not know about the free weekly ibuprofen because nobody asked, and the person taking it does not mention it because it is over the counter and therefore not considered a medication in the same category as their prescription drugs. Other blood pressure-raising substances that are consistently overlooked include decongestant nasal sprays containing oxymetazoline or xylometazoline, which cause systemic vasoconstriction when overused. Oral decongestants containing pseudoephedrine, common in cold and flu preparations. Combined oral contraceptive pills in younger women with hypertension. Licorice, the herbal form found in certain teas, supplements, and confectionery, which contains glycyrrhizin, a compound that mimics aldosterone and causes sodium retention. And high-dose vitamin D supplementation, which at doses above 4,000 IU daily can cause hypercalcemia that raises blood pressure through vascular calcification and direct vasoconstriction. Each of those is a reversible cause of blood pressure elevation. Each of them requires a question to identify. The question, tell me everything you take, including over-the-counter medications, supplements, herbal products, and anything else, is not consistently asked in the standard blood pressure review. And the answer, when it is given fully, frequently, contains the agent that is undermining the treatment. Here is what is actually happening inside the body when ibuprofen is taken alongside antihypertensive medications. The prostaglandins that ibuprofen inhibits are responsible for maintaining adequate blood flow to the kidney's filtration units. When those prostaglandins are suppressed, renal blood flow falls. The kidney, detecting reduced perfusion, activates the renin-angiotensin-aldosterone system as a compensatory response, the same system that the ACE inhibitor is supposed to be suppressing. The ibuprofen is reactivating the mechanism the ACE inhibitor was blocking. The blood pressure rises. The evening reading recorded in Reginald's wife's notebook goes up. The cardiologist considers adding a fifth medication. The ibuprofen is not on the list being reviewed because it was bought over the counter and therefore does not feel like a medication in the same way. Research from the British Journal of Clinical Pharmacology confirmed that regular NSAID use in adults taking antihypertensive medications raised systolic blood pressure by an average of 5 millimeters of mercury, a clinically significant amount that, in someone whose blood pressure is already borderline controlled, is the difference between a reading that is acceptable and one that prompts a medication escalation. 5 millimeters. From a drug bought over the counter for knee pain, never mentioned, never connected to the blood pressure. That will not come down. Now I want to give you the plan, because everything I have described has a specific, identifiable investigation pathway and a specific, evidence-based management approach. This is not a problem that requires indefinite medication escalation. It requires the right investigation before the next medication is added. I call this the Resistant Hypertension Investigation Protocol. 5 steps to be initiated at your next medical appointment. Step 1. Request a 24-hour ambulatory blood pressure monitor. If you have resistant hypertension, blood pressure that is not adequately controlled on 2 or more medications, and you have never had one, use these exact words at your appointment. I would like a 24-hour ambulatory blood pressure monitor to assess my nocturnal blood pressure profile and dipping status before any further medication change is considered. That request is clinically appropriate, is supported by international hypertension guidelines, and should produce the referral without resistance. The result of that monitor will tell your cardiologist more about why your blood pressure is resistant than any number of additional clinic readings. Step 2. Request a sleep study evaluation if you have any of the features I described: snoring, witnessed apnoeas, unrefreshing sleep, morning headaches, excessive daytime sleepiness, or nocturnal urination. In the United Kingdom, this is available through a GP referral to a respiratory sleep service. In the United States, through sleep medicine departments at most hospital systems. A home sleep test, a simplified monitoring device worn overnight can identify obstructive sleep apnea without requiring an overnight hospital admission and is the starting point for most evaluations. If apnea is confirmed and treated with CPAP, the blood pressure response in the weeks following treatment initiation is frequently significant enough to prompt a medication review. Not an addition. A reduction. Step 3. Request an aldosterone to renin ratio blood test specifically if your serum potassium has been low or at the lower end of normal, if we have resistant hypertension on 3 or more medications, or if you are younger than 55 with severe hypertension that does not fit the expected clinical picture. That test, combined with a CT scan of the adrenal glands, if the ratio is elevated, would either confirm or exclude primary aldosteronism as a contributing cause. If confirmed, the treatment either surgical removal of the affected adrenal gland, if the cause is unilateral, or mineralocorticoid. Receptor antagonist medication such as spironolactone addresses the mechanism rather than the consequence. Blood pressure frequently normalizes or becomes significantly easier to control. Step 4. Review every substance you consume, prescription, over-the-counter, and supplemental with your GP or pharmacist, specifically for blood pressure-raising effects. Bring a complete list. Include ibuprofen even if you take it only occasionally. Include any nasal spray, include any herbal tea or supplement, include any product that contains licorice extract. Ask specifically whether any item on that list has a known blood pressure-raising mechanism and whether a safer alternative exists for its indication. That review, done thoroughly, sometimes produces a single substitution that achieves what 4 medications could not. Step 5. Review the timing of your blood pressure medications with your prescribing physician. Research from the HiGA chronotherapy trial, one of the largest blood pressure medication timing studies ever conducted, found that taking at least one antihypertensive medication at bedtime rather than in the morning produced significantly better nocturnal blood pressure control and significantly reduced cardiovascular event rates compared to morning dosing alone. If your ambulatory monitor shows a non-dipping or reverse dipping pattern, the timing of your medication delivery may be part of the solution. Evening dosing of at least one agent, particularly the ACE inhibitor or ARB, targets the nocturnal pressure at the time when it is most active. That conversation requires the ambulatory monitor data to support it, which is why the monitor comes first. I want to come back to Reginald. After his ambulatory monitor confirmed the reverse dipping pattern and his sleep study requested on the basis of his wife's observation that he snored heavily and occasionally seemed to pause his breathing, confirmed moderate to severe obstructive sleep apnea with an apnea-hypopnea index of 43 events per hour. His management was restructured entirely. CPAP therapy was initiated. His ACE inhibitor was moved from morning to evening dosing. His ibuprofen, which he had been taking 3 times weekly for hip osteoarthritis and which had not appeared on any medication list reviewed in 4 years, was stopped and replaced with paracetamol and topical diclofenac gel, which carries a significantly lower systemic blood pressure effect. At his 8-week CPAP review, his wife reported that the snoring had stopped on the first night of treatment. He was waking refreshed for the first time in years. His morning headaches were gone. His daytime alertness, which he had attributed to normal aging, had transformed in a way he had not anticipated. His blood pressure at 8 weeks was 134/82, the lowest reading in 4 years of treatment. On the same 4 medications, without a 5th agent, without any dietary change beyond the removal of ibuprofen, the cause had been addressed. The consequence was resolving. He came back to see me 4 months after CPAP initiation. He sat across from me with the particular satisfaction of a mathematician who has found the error in the working that was producing the wrong answer. He placed his wife's notebook on the desk between us. He had continued the evening readings. The last 14 entries were all below 140 systolic. He tapped the notebook once with his finger and looked at me. And then he said the thing that has stayed with me since. He said, 4 years. 4 medications, one question that nobody asked. He paused, and then with the quiet precision of a man who has spent his career teaching young people to examine their assumptions, he said. The assumption was that the blood pressure was the problem. It was never the problem, it was always the answer my body was giving to a question nobody had thought to ask. That sentence has stayed with me ever since. It is a significant part of why I make these videos. Because resistant hypertension is not primarily a medication problem, it is an investigation problem. The medications are targeting the answer. The question, why is the blood pressure rising, has not been asked completely. And until it is asked completely, until the nocturnal profile is measured, until the airway is assessed, until the aldosterone to renin ratio is checked, until the full substance list is reviewed, the answer the body is giving will not change, regardless of how many drugs are added to the morning pill organizer. Let me say each cause one final time. Obstructive sleep apnea, the most common hidden cause of resistant hypertension, operating through nightly sympathetic surges that chronically upregulate blood pressure day and night. Identifiable with a sleep study, treatable with CPAP, primary aldosteronism. The second most common, operating through autonomous adrenal aldosterone production that drives sodium retention independently of the renin-angiotensin pathway, identifiable with an aldosterone to renin ratio blood test. And hidden blood pressure raising substances, NSAIDs, nasal decongestants, herbal products, high-dose supplements, operating by reactivating or overriding the mechanisms that antihypertensive medications are designed to suppress, identifiable with a complete and thorough medication and supplement review that includes everything taken regardless of its prescription status. 3 causes, 3 investigations, 1 principle. The blood pressure that will not come down is not evidence of inadequate medication. It is evidence of an unasked question. Which of these 3 causes do you recognize as potentially present in your situation? Do you snore? Have you been taking ibuprofen alongside your blood pressure medication without mentioning it? Has your potassium been low, and has anyone ever checked your aldosterone? Tell me in the comments below. I read every single one, and your answers tell me how many people are adding a 5th medication when what they need is a first investigation. If this video gave you a reason to have a different conversation at your next appointment, share it. Not for me, for the person in your life who is taking 3 or 4 blood pressure medications and watching the evening readings stay stubbornly too high despite everything they have done. Who is being told their hypertension is resistant without anyone having explained what resistant actually means or what the investigation pathway for it looks like. They may not know that the question has not been asked completely, but you do now. And that is exactly why you are here. And if you have not subscribed yet, please do. Every week I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing, and this is important. Everything I have shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. Please do not stop or change any blood pressure medication without speaking to your own physician first. They know your history. They know your clinical picture. I do not. This is education. Use it as the beginning of that conversation. The conversation that Reginald wishes someone had started with him 4 years earlier.